The topic of our event today is bone marrow transplant in AML and MDS. This was a topic requested by one of our community members. At the end of today's event, I'll provide my email address. If you have a topic you'd like to see us cover, please reach out so we can get it on our schedule. I love being able to address topics that our community is specifically interested in, so don't hesitate to send over questions or areas of interest. Now I'm going to introduce our speaker, Dr. Khera. Dr. Khera is a hematologist oncologist and associate professor of medicine at the Mayo Clinic in Scottsdale, Arizona. The goal of Dr. Khera's research is to better inform and prepare patients for the psychosocial and financial consequences of treatment, irrespective of their socio-demographic profile. I am so excited to have her here with us today, and so I'm going to go ahead and turn our presentation over to her.
Thank you, Mary, for that introduction. And I will share my screen. Can find the presentation. So many screens open, so I'm trying to find my presentation here. Sorry. All right. Are you able to see the slides?
Yes.
Great. So thank you again for the introduction. I am really happy to be here today to talk about this topic, bone marrow transplantation for myelodysplastic syndromes and acute myeloid leukemia. I am an adult bone marrow transplant physician here at Mayo Clinic, Arizona. And so just my disclosures. So over the next few minutes, I hope to talk to you about the role of transplant for MDS and AML. What are some of the reasons we consider this as a treatment? And then describe some recent literature on the role of transplant in these two diseases. Following that, I would just very, very briefly overview what the process and the considerations are for an allogeneic hematopoietic cell transplantation for these two diagnoses. And we'll end by going over factors impacting the success and how to prepare for transplant. All right, so myelodysplastic syndromes are a group of bone marrow stem cell cancers that are defined by low blood counts, marrow dysplasia, which means abnormal looking cells when the pathologist looks at them under the microscope, and chromosome changes or genetic mutations. Usually it is characterized by need for transfusions and risk of infections because of low white blood cell count. It can range from very low severity disease or indolent type of disease to very high severity and with a high risk of transformation to full-blown leukemia. And I will show you in the next slide what are some of the factors that affect that risk stratification. It is uncommon before the age of 50 years. Mostly it is seen in our older population in their 70s. And the numbers, as I mentioned, it's a relatively rare cancer if you were to compare it to like breast cancer or lung cancer. The number of patients living with MDS in US is estimated to be between 60,000 and 170,000. So what are the risk categories for myelodysplastic syndrome? How do we determine the risk? We look at which blood counts are low. Is it just the red blood cells? Is it the white blood cells? Is it platelets? Is it a combination of all three? We look at the number of blasts, which are the abnormal cells in the bone marrow that the pathologist tells us. And then we look at the type of chromosome changes. So based on these three factors, we have a risk scoring system called RIPSS that was developed by Dr. Greenberg and others. And it very nicely showed an impact on the survival. So our patients who were in the very low category had a great survival as opposed to those with very high risk category in the blue line here. And again, when we look at the risk of transforming to AML, the very low risk category obviously had the lowest risk of transforming to AML versus the ones with very high risk disease. And as you all may know, now we have even more information available to us in terms of the molecular markers or the genetic mutations. And so recently, this system, this risk stratification system, was updated, and it's now called IPSSM, which includes some of these mutations that are also looked at when we do a bone marrow biopsy in a patient with myelodysplastic syndrome. And again, it characterizes people from very low risk, medium low risk, medium high risk to high and very high risk categories based on certain types of mutations and how frequently they are occurring in the bone marrow. And they again show a very nice sort of stratification in terms of worsening outcomes as the risks or the high risk mutations go up. So how do we treat MDS? The treatments can range from supportive care, so transfusions, growth factors as needed, and really minimal medical interventions for some of our patients with the low risk disease, to disease modifying treatments, or most commonly the ones that we use here are the hypomethylating agents. But what we know is that even though the treatments can help change the natural history of the disease, they don't really cure it. So the only curative therapy that we have at this time for myelodysplastic syndrome is hematopoietic cell transplantation, or also known as bone marrow or stem cell transplantation. So, how do we decide whether we should transplant somebody or not? And so, especially as I mentioned, MDS is a disease of our older patients, and transplant is a high risk procedure leading to really high toxicity sometimes in our older patients. So, what was done was an observational study by our registry that showed that outcomes after transplant in our patients above 55 years of age were very comparable to uh, those who were undergoing transplant and were less than 55 years of age with MDS. And so, based on that observational study, where we saw a signal for the benefit of transplant, the Clinical Trials Network, which is an organization that conducts multi-center clinical trials in the field of transplant and cell therapy, they came up with the idea of doing this biologic assignment trial. So you may have heard of randomized clinical trials or placebo-controlled randomized trials, and those are slightly different because that's where you have a 50-50 chance of ending on the treatment arm or on the control arm based on what the computer decides. This is a biologic assignment trial whereby patients who were 50 to 75 years of age and had high risk myelodysplastic syndrome went on to get a transplant if they had a donor available, either a matched sibling donor or a 10 out of 10 matched unrelated donor. And the ones that did not have a donor available went on to receive just the chemotherapy treatment, basically whatever their doctor decided. And this trial, which was a large study with 260 patients in the donor arm and 124 in the no donor arm, showed that when we looked at the outcomes at 3 years, so overall survival at 3 years after transplant or no transplant based on their donor availability, showed that there was a benefit of doing transplant with 47 or almost 48% survival in the transplant arm versus the no donor or no transplant arm, which was like 27% or so. This here down is a funnel plot, and it looks at certain factors that can impact the outcomes. And the vertical line is basically no difference from the intervention. And anything that is on the right side shows that there was a benefit of having a donor and moving on to transplant. And basically, what it shows is a lot of the factors or a lot of the subgroups that we looked at in all of those groups, whether it was older or higher age, how long the MDS had been present, or their risk category, the having a donor and being able to go to transplant was better in terms of outcomes than having no donor. When they looked at the 3 year estimates for the um, leukemia free survival, that was again still better in the ones that had a donor and were able to move to transplant as opposed to those that did not go to transplant. They also looked at quality of life, which is again an important thing for our older patients. And what they saw was the quality of life was very similar in both groups, whether they went to transplant or did not have a transplant. And this was measured at various time points after enrollment. When we were doing this study, the Europeans, specifically the Germans, were doing another study, which is called the Videsa Allo study. And again, they were doing something very similar, but here specifically they were comparing this 5-azacitidine or Videsa, as some of you may have heard, with the allogeneic stem cell transplant. And everyone got a few cycles of the 5-aza, and then some people, or basically this was more of a randomized study, so 50% of the people ended up on transplant and 50% continued the chemotherapy. And here again, this was smaller than the previous study, but still we would consider it a large study in our heme world, where they had 81 patients on the transplant arm and 27 on the continuous chemotherapy arm. And the red, which is the transplant arm, again showed better event-free survival, which was statistically significant. The overall survival here was better, but the statistical significance was not achieved. And I think that was partly because the numbers were lower than the previous study. Again, when we look at the right side here, that's where they showed that anything on the right side of this vertical line means the transplant is better, and that was true for most groups, including either based on like gender, male or female, age, or the risk category, the functional status, and so forth. So then a question that often comes up is, and TP53 is one of the really bad mutations that our AML and MDS patients can sometimes have. And their disease tends to behave really aggressively. And there were some questions in the community, in our scientific community, to say, that patients who have P53, do they even benefit from transplant? If they have such bad disease, does transplant really give them any benefit? And so, from the first trial that I mentioned, the Clinical Trials Network, what they did was they actually were able to do some more studies in looking at the patient based on the blood samples and the bone marrow samples that were collected. And they looked specifically at patients with P53 and compared them to those with no P53 mutations. And what they showed was in the all comers, there was definitely still a benefit of transplant as opposed to no transplant. When they looked at the IPSSM very high risk category, which again, I just to remind you, and that's the newer system, which includes the information about molecular markers or mutations. So when they looked at these very high risk patients who had TP53, what they saw was the overall survival was quite comparable between donor and no donor, or moving to transplant and no transplant. However, if you were a very high risk category based on IPSSM, but you did not have TP53, in those, the transplant people did much, much better than those who did not have a donor and did not go to transplant. So I would say, I think what we learned from this data was that in a certain group of patients, even with the bad P53 mutation, there may still be a benefit of transplant rather than not going to transplant. Now, that is a nuanced decision, obviously, that needs to be made by the transplant doctors and your treating doctor. Moving on to acute myeloid leukemia. So AML is a group of aggressive blood cell cancers that arises from clonal expansion. So clonal means there is a certain group of cells with certain genetic mutations that starts to expand, that starts to increase in the bone marrow and starts to replace the normal cells in the marrow. And these leukemic cells, they interfere with the production of normal blood cells. And that's why in the blood, when we do blood work, we see low white count or low hemoglobin, low platelets, thus causing weakness, infection, bleeding, etc. Now, also to remind, sometimes the white count can actually be high, especially if these bad leukemic cells start spilling in the blood. So it can be both a low and a high white count that sometimes we can see with AML presentations. Again, it's relatively rare, especially when you compare it to certain solid tumors. Counts for like 1% of all cancers in the United States. There's around 20,000 cases that are estimated to be happened in 2020 or will happen in 2024. And the median age, again, is older patients, approximately around 68 years of age. So again, similar to MDS, we have a risk system here, and this is again based on either the chromosomal markers or the genetic mutations. And why is this risk system important is because one is obviously it helps us assess the prognosis, meaning how will a patient with AML do? But more importantly, it also helps in certain treatment decisions where we know that most patients with what we call the favorable risk category, which is all of these different types of mutations or markers, will likely be able to get their AML cured just by chemotherapy alone. Whereas these two other categories are a little bit higher risk in terms of they may need something in addition to just chemotherapy to be able to get cured. And that's where the transplant comes in again. So I would like to mention that this adverse risk category is probably the one where we feel that if a patient is otherwise a candidate for going to transplant, they should go to transplant as soon as we are able to get them into remission. This category, mostly we try to keep people just on chemo, give them high doses of like cytarabine or something for consolidation, and try to avoid transplant if we can, unless they don't meet certain milestones. The intermediate category is the most gray area where again it's a very nuanced decision. You have to look at all many different factors to decide if someone with an intermediate risk AML should or should not go to transplant. So it used to be, I would say, even 10 years back, it used to be for AML, we said, okay, we do induction and then we do consolidation, and that was it. Unlike ALL, which is a different type of leukemia where we had this induction, consolidation, and maintenance. I would think that the AML paradigm has changed also now with induction treatment, consolidation, and then there may be a need for maintenance. So, what is induction? Induction is basically when somebody presents to us with AML, it means that they have more than 20% bad cells or leukemia cells or blasts in their blood or marrow. So, our goal with the induction treatment is to try and get that 20% down to zero, um, preferably, if not at least to less than 5%. Once they go into induction, that by itself is not enough. Um, Even if they attain 0% or less than 5% blasts after the treatment with this, they still need more treatment to make sure that that is sustained. So while induction usually can be with high doses of cytotoxic chemotherapy that require a hospitalization for 3 to 4 weeks, we sometimes will do more gentler chemotherapies or even targeted agents now that we have against certain mutations to try and get people in remission. And then comes consolidation, which usually is done with high doses of a chemo called cytarabine or allogeneic transplant, depending on what risk category our patient is from. And now we know that even after consolidation, even after transplant, there are patients that may need some maintenance treatment to try and decrease the risk of the AML coming back. Or for that matter, people who are not able to go to transplant, they may get induction. They may or may not get any consolidation, but then they could need to be on maintenance for a long, long time to try and prevent the leukemia from coming back. And that's usually in our older patients or patients with a lot of comorbidities for whom transplant may be a very high risk. And maintenance is usually, again, done with either targeted agents or with gentler chemotherapies called decitabine or azacitidine. We now have oral forms of these as well to help with maintenance. So How do we decide who goes to allotransplant if they have AML? So, what we need to assess is relapse risk. And that relapse risk depends on a few factors, including whether this is primary or secondary AML. What is the difference here? Primary is if the AML occurs just all of a sudden, really nothing was going on, and somebody just gets diagnosed with it. Secondary is when either somebody has some sort of an underlying blood process. So they could have an MDS or even what we call myeloproliferative disease, and that could turn aggressive and turn into leukemia. Or it could be that they had another type of cancer and then they got chemo or radiation for that. And that chemo or radiation then had basically caused them to get AML, and that would be called secondary AML also. And there are certain genetic markers that go along with secondary AML. Usually they belong to the poor risk category that I showed you, the adverse risk category in that risk system. We then look at the chromosomal markers and the mutations. Again, based on that, we define what risk category our patient is in. And we look at response to induction chemotherapy. I always tell my patients, there are markers that you will have at diagnoses, but then there are also milestones that we'll be following you for that will determine whether you need to go to transplant or not. So, for instance, somebody might start off in the favorable risk or the good risk and may not have needed transplant based on how they were at diagnoses, but they don't respond to the induction chemo, meaning we are unable to get their blasts down to less than 5%. So that is a patient that might need to go to transplant rather than just do chemo alone. So based on all these factors, we decide or we try to estimate would the risk of relapse be around 40% or so. And this 40% is, I would say, a little bit subjective. There may be people who may be thinking it is more like 50-50. But in general, I would say if the risk of relapse is really low, meaning less than 40%, then in that case, I think we can treat the patient just with chemotherapy and not have to go to transplant. If the risk is high, so it could be that they have secondary disease AML, or they have what we call adverse risk findings on their genetic markers, or they don't respond to induction chemotherapy, in which case we know that the risk of relapse would be 60-70%. In that case, the next step we do is we try to assess what is the chance of a bad outcome with transplant going to be, and that is what we call TRM, or transplant related mortality. And some of the factors that go into that assessment are how old the patient is. And age by itself is not like just a sole thing. We try to look at age in the context of other things such as comorbidities, or what are some of the other medical problems that the patient has. And then who is the donor going to be? Because we know that certain times the mismatched donor or half matched donors are going to be slightly higher risk than what we would do with a matched sibling or a 10 out of 10 matched unrelated donor. And we'll talk about the donors a little bit more as we talk about the transplant process. So if we feel that the TRM, or the risk of toxicity, will be very high, which is, if a patient is more than 60 years and they have a lot of medical problems, then in that case, we may decide not to proceed to an allotransplant because the risks would outweigh the benefits that we could give them. If, however, we feel that the predicted TRM would be low enough, then in that case, we do start looking at moving forward with the plan of transplant. As I mentioned, the intermediate group is kind of a gray area. So this was a European study that they looked at AML patients with intermediate risk AML, and they randomize them to chemo consolidation or allotransplant. So 67 patients got chemo for consolidation, 76 got allotransplant. And they basically looked at overall survival for the two groups. And what they showed was that the overall survival was comparable, um, comparing the chemo only patients to allotransplant patients. And the only thing I would say is what I don't show here is when you look at the leukemia-free survival, meaning how long patients lasted without their leukemia coming back, that was better in the patients who had gotten a transplant than those who got chemotherapy. And the reason partly that their survival, overall survival, was equal or comparable is because all of their patients who got combination just the chemotherapy and ended up relapsing were still able to go to transplant by getting salvage treatment and then moving on to transplant. So even the authors said, even though they found the survival was comparable, but they do mention that cumulative exposure to chemo can be much higher in the chemo only group. And so that should be kept in mind if we have a patient that we feel should go to transplant when they are in their first remission, as opposed to allowing them to relapse and then considering transplant. So, what is allogenic hematopoietic cell transplant? This is a procedure in which we replace the bone marrow that we think is diseased or damaged with stem cells from another donor. And the rationale for this is that we feel that the new immune system or the transplanted immune system will recognize the cells that may have survived chemotherapy or radiation and attack them and eradicate them. And this is called graft versus tumor effect. And this is the important immunological benefit that chemo itself does not give you. And that's why transplant can be potentially curative. What are the risks and benefits of transplant approach? So some of the risks are high risk of complications like infections. There's something called graft versus host disease, and then there's organ toxicity. It can affect kidneys, liver, heart, any organ of the body. Somebody who's frail or has a poor functional status may actually do worse with transplant than with not doing a transplant. Donor availability may be an important consideration, although I will show you that right now that is not really an important factor. And then, financial and logistic aspects are important too, because insurance coverage is this is a really expensive procedure, and we have to make sure that the insurance can cover and the patient will not have to face financial challenges because of this. The benefits are for patients with high risk MDS or AML, which we know are not cured by our available chemo treatments, especially the ones who have poor risk genetic mutations or are not responding to non transplant chemotherapy type treatments. And then the major benefit is the potential of cure, which really at this time, none of the other treatments other than transplant offer us. How do we decide which treatment approach, non transplant or transplant, is better? We look at the patient age and fitness. We look at what their disease risk category is, if they are in the low risk or high risk or intermediate risk. And we look at the risks of treatment. We try to assess whether the patient will be able to tolerate their treatment or transplant or not. And finally, we do look at patient goals and wishes. Sometimes quality of life is more important to people than quantity of life, and that is an important factor that should be taken into account when deciding for transplant versus no transplant. So, first question that comes up is who will be the donor for the transplant? We prefer a matched sibling, which we know is not available for everyone, especially for our older patients who may have siblings that are even older to them or medically not fit to be able to do stem cell donation. However, we have really good registries that keep an information about unrelated donors. So we try to look for matched unrelated donors in the registry. It used to be that the if we so what we look for is 5 markers on the cells called HLA markers, and since we have 2 chromosomes, we call it a 10 out of 10 donor if there is a match at all 5. So people who do not have a 10 out of 10 donor and only have say 8 or 9 out of 10, what do we do for those? Now we have our scientific field has advanced to a point where we know that people who can still get transplants from like half match donors. So usually children will be a half match. For some younger patients, parents would be an option. And then sometimes siblings may not be a full match, but maybe a half match. So our field has advanced to a point with newer regimens that most everyone who needs a transplant, we should be able to find a suitable donor with some manipulation of how we do the transplant, and that decreases the risk of even using mismatched donors. The second thing to know is preparative regimen or conditioning. And what that is that I tell my patients, I cannot just give you somebody's cells just like that. Your body would reject them. So I need to suppress your immune system. I need to create space in your marrow for those cells to come in and settle down. When they started doing transplants back in 1960s, they used to use high doses of chemo or radiation to do that. But we know that it's not tolerated by our older patients or those with medical problems. So we usually keep these regimens, what we call myeloablative regimens, which are very intense, strong regimens for for our younger patients and those who have no other medical problems, and or those with really aggressive disease where we want to give them the benefit of chemo in addition to the immune benefit from transplant. For most of our older patients, what we use is a reduced intensity or non-myeloablative transplants, which still give us that immunological benefit that we hope to get, but do not have the same amount of toxicity as the strong, intense regimens would have. So how do we go about doing this? So initially, what usually happens is that the transplant team gets a referral from the treating doctor, and then the patient will meet with the transplant doctor, and usually it's a whole team because transplant requires a lot of different people to be working together. And so most transplant centers, you have teams of staff that help get a patient through transplant. And this team will work with the treating doctor on developing a care plan. They do a search for a donor. Once we have selected a best possible donor, we decide on dates of transplant. That again will depend a little bit on where you are with your treatment. And once that date is decided, we sort of work backwards from that and do a very comprehensive, very thorough clinical evaluation, because what we want to know is the patient's body, will they be able to tolerate the intense transplant. Once that is decided, once that is all done and is good, then you're admitted to the hospital. You get the conditioning, which usually is a combination of some chemotherapy plus minus some radiation. Then you get the stem cells. Then the new cells will start populating the bone marrow and growing into new cells. That usually takes about anywhere between like 12 to 20 days after getting the stem cell infusion. And once things are better in terms of counts and patient is doing well, they're discharged from the hospital. But most transplant centers continue to follow very closely their patients in the outpatient clinic for the first 100 days after transplant. What are some of the potential complications? And we could spend a whole day on this, but I tried to put it in one slide. So there's something called acute and chronic graft versus host disease that can start from early on and basically can last for years after transplant. There's something called veno-occlusive disease, which is basically liver injury from the chemo that we do for transplant. And the incidence of that has gone down. It used to be very high. It used to be really a bad thing to get because we didn't have good treatments for it. But thankfully, the risk has gone down, and we have now treatments that are relatively, reasonable to be able to treat this. And so, but this is still an important complication to remember. And then infections, because of the immunosuppression, any type of infections, bacterial, viral, fungal infections, and they are common from early on to even long time, many, many years after transplant. And then usually there are late effects such as heart complications, second cancers, but those usually happen later in the course, mostly years after the transplant. So, what is graft versus host disease? It is basically an immunological complication of the transplant. It occurs because of the difference between the patient cells and the donor cells, and the severity can range from mild to life-threatening. So there's two types, acute and chronic. Usually acute is the one that occurs in the first 100 days, but it can happen even afterwards, and usually it is skin rash, nausea, diarrhea, or liver function abnormalities. The chronic is more like an autoimmune problem, and it can cause problems like skin issues, dry eyes, dry mouth, lung issues, joints, etc., and it can adversely impact long-term quality of life. Um, Again, I didn't show it here, but now we have really good regimens that help prevent the severe graft versus host disease, which used to be a really life-threatening complication of transplant. And that is, again, a progress in the field that we have made. In terms of long-term effects, as I mentioned, it can affect quality of life, health, and functional status. We know that our transplant survivors who have these late effects or chronic health conditions can have lower physical functioning. Their likelihood of returning to work or study can be lower than those who don't have these problems, and their likelihood of being limited in their usual activities is higher, and higher incidence of distress overall is seen. So, what determines the success of transplants? In general, we consider that the transplants will be the most successful if there are disease specific factors that are met. So, for instance, the MDS patients, if they are in remission at the time and have not transformed to leukemia, their chances of success are higher. In AML, again, we hope that the patient can be in remission because that will improve the chances of success. And now we have these sophisticated tests that can detect really, really small amounts of leukemia, like even 1 in 100,000 to 1 in a million cells. And so ideally, we would want even those tests to be negative to ensure the maximum success with transplants. However, it's not a deal breaker, meaning if somebody is in remission, but they may still have some minimal residual disease, hopefully they can still go to transplant and eradicate that low level disease as well. The other things that are important or need to happen to be able to get to transplant and be successful are good organ function. So, heart, liver, lung, kidneys, all of those have to be functioning good. Optimum functional status. If somebody comes to me in a wheelchair, I usually will say, unless you were able to be more active, I don't think I can take you to transplant. Infections, because a lot of our patients have been on chemo before and their counts have been low or they've been immunosuppressed. Sometimes they can have even really bad infections before coming to transplant. So making sure that all of that is controlled with appropriate treatment is important before going to transplant. And then most importantly, I feel like psychosocial support is really, really an important component of a successful process of transplant. So, what can you do to prepare for the experience and get a better chance of success? You can ask for information about risks and benefits of transplant from your doctor. You can explore non transplant options such as clinical trials. If you've decided or your doctor has decided that you need to go and be seen by a transplant doctor, then selecting a transplant center is important. Usually, it's dictated by the insurance company as to what they will cover. But important thing to realize is that you have to be living within usually an hour of the transplant center for the first 100 days. So for some people, it may mean that they need to move out, from where they live to be closer to the transplant center for at least 3 months or so after transplant. Patients always ask me, what can I do while, all of the the preparation is happening? I usually tell them continue to stay active, continue to eat as good as you can to build a nutritional buffer before we hit you hard with transplant and your nutrition goes down. Important thing is deciding about a caregiver because most transplant centers would require a caregiver to be with the patient 24/7 for that first 100-day time period. And then planning for financial aspects, financial impact is quite important too. um, I don't know if we have some caregivers here, and so there may be questions about what can you do as a potential caregiver. We usually expect three main areas of support that you can provide to your patient. One is obviously medical, gathering information, talking to the doctors, asking questions, and helping overall provide care for the patient. Financial aspect, if your patient is too sick to do this, then you may be the one needing to talk to the insurance company how to manage transplant costs, daily financial aspects, and so forth. And then, most important, emotional and social, just being there to listen and support your patient. And as they go through this very difficult journey, I think that is a very important responsibility for our caregivers. However, we do realize that. Our caregivers sometimes have bad outcomes just because they kind of just put everything towards taking care of their patient. And so it is very, very important to realize that taking care of yourself while caring for your loved one is important. And we have many resources now that are available for supporting our caregivers. So just to conclude, allotransplant is curative for both MDS, AML. Usually we do it for patients who have high risk disease. Usually, we have to find an available donor. And again, most patients that we would take to transplant have to be medically fit with good functional status and somewhat limited or controlled medical problems. So somebody could have a heart disease, but as long as they've been seen and cleared by cardiology, it's okay. When we would prefer that you see a transplant doctor and a team as early as possible in the disease course, and they can decide when and how to move to transplant rather than your non-transplant doctor who may not be aware about some of the progress that we have made in our transplant field and know about the assessments that we do. And then how, as I showed you, it's a complicated multi-step process involving a lot of different people, a lot of different stakeholders, and there is a need for prolonged follow-up. So one has to be ready for that when they decide to go to transplant. So with that, I will end and happy to take questions.
Thank you so much for that presentation. That was incredibly informative. I feel like I learned a lot. Um, it's now time for the discussion Q&A part of today's event. If you have any questions about bone marrow transplant or anything Dr. Khera spoke on today, now's your chance to ask questions. We set this time specifically aside for our community members to have a chance to talk to our presenters. So please feel free to ask questions if you have any. As a reminder, you can ask them by making a comment in the chat box or by raising your hand if you'd like to ask a question verbally. So it looks like we have one question in the chat so far and then one raised hand. So we'll do the question in the chat and then we'll get to our verbal question. So this question is, hi, I'm 69 years old. I have mutated, let's see.
ASXL1.
Actually, it's
Yes,
still on here.
yes.
I'm the same one raising my hand. Shall I read it? So,
Oh, okay,
is that
yes, go
okay?
ahead.
Yeah, so
Yes.
I'm 69 years old. I was diagnosed a year ago with the the biopsy, which showed I'd got these 3 mutations, which you showed in your adverse slide, the one called the LN 2022 risks. Although I've always been told I'm low/intermediate risk. And more recently, they called it low risk. But when I look at your slide, it's like I've got 3 of the nasty ones in your adverse block. I'm really healthy. I mean, I've got very low hemoglobin and my platelets, actually, they're continuing to fall. Starting to get a little bit of bruising, but basically fit, healthy, running around. I have a pretty good hematologist, and he said, we'll have another biopsy at some point. But I'm just wondering, from listening to you, should I be really thinking actually I am probably quite a high risk of going to AML with these 3 mutations? I mean, I'd love your view on these mutations.
Sir, thank you for the question. Just to clarify, did the biopsy show MDS or AML?
It was MDS with
Okay.
suspected MPN overlap.
Okay.
But during the year, and it would have been MPN ET, but actually my platelets have gone from too high to far too low
Too
now.
low. Yeah.
And they think the MPN may have lost out to the MDS. I don't know if they fight each other or something.
Yeah. No, so again, without knowing all the details about it, all I would say is you should at least see a transplant doctor and have a discussion about the risks and benefits, because I am seeing some sort of markers that may make the disease. So even if the disease is going like this now, I worry that it may be starting to take a turn, become more aggressive. And if we lose that window and, the MDS then transforms to AML, that's going to be harder because then your body, you will have to get more treatment first to be able to get into remission. So I would say the best, usually that's what I tell patients, is have a transplant doctor evaluate you, look at the risk stratification, and look at, I'm thinking if I were to calculate your IPSS-M, that would actually be on the higher risk side based on these bad risk mutations. And so that is what I would say. But again, not knowing, what are the medical problems you have and things like that, it would again be a more nuanced decision that somebody who can see you and have all the details available would be a good idea. So I would, even if you say that, I'm not saying push for transplant, I would say push for a consult with a transplant doctor so that they can evaluate you well, in terms of the
But I
relapse
should
risk, the
be
risk
concerned
of
with
toxicity, and so forth. Yes.
these three mutations. Thank you
Yes,
very much. Thank you.
absolutely.
Thank you.
Thank you for that question. We have another question. Other than insurance, how should a patient go about choosing a transplant center? I live in the US Northeast.
So, you know, again, there is publicly available data on the transplant centers as to how they do, meaning, so it's called SCTOD data, and our registry does that, where they look at all the transplant centers and try to see if centers are functioning above the standard threshold or below. And so that is a publicly available database that you can look at centers that are doing really well, who may be in your vicinity, that you could approach. There are, again, going back to the insurance question, sometimes insurances have centers of excellence that they may be referring you to, and those are usually chosen based on that publicly available data on outcomes. But in general, the proximity to the transplant center, your comfort level, once you meet with the team, you will know how this is going to go. I mean, sometimes we get patients who've seen have been seen at two other transplant programs, and for some reason, they say, oh no, we would want to stay here, we just feel like it's more comfortable. So I think it's your own comfort level, your proximity, to the transplant center, and then you can definitely look at that database to make sure that that center is not really functioning at a level lower than the standard, to be able to get seen.
Thank you for that answer. We will send it's an online database, correct?
Yes.
Okay, we'll send the link for that in the post-event email as well, so people can use that to refer if you're looking for a transplant center. Our next question is, how do you know if GVHD is chronic?
Good question. So it used to be very simple. It used to be anything that happened before day 100, we called it acute, and anything after day 100 was chronic. However, in 2005, they did a chronic GVHD consensus conference, and that's where they decided that it was more based on symptoms and presentation that we would call it acute or chronic. So acute is mostly, if it's like reddish, prickly heat type of skin rash, nausea, vomiting, diarrhea, or liver function abnormalities. And that can happen before or after day 100. And it's called classic acute before day 100, late acute after day 100. Chronic is more, again, symptom wise, it's more of the autoimmune type of problem. So dry eyes, dry mouth, can have lung issues similar to COPD. In the skin, it can cause skin tightness or, scleroderma-like changes where the skin feels like tight, or you cannot pinch the skin off. So those are some of the manifestations of chronic. So it's all based on how you present clinically, whether it's acute or chronic.
Thank you for that answer. I know GVHD is something that a lot of our patients have questions about, a lot of them experience, so I think that distinction is helpful in figuring out what exactly they're dealing with. Another question, how does the TP53 in AML affect children born to a parent with this mutation? Can they be genetically tested early to see if they have that mutation?
That's a great question. And, obviously, I did not go over, but when they came up with the new ELN classification for risk, they also had a whole section about some of the what we call familial or genetically transmitted mutations. So P53 usually is a somatic mutation, meaning it happens in the patient, but usually will not be transmitted or did not usually come from their previous generation and usually will not be transmitted to the next generation. There are other mutations, though, that can be more familial, and those are the ones that we worry about, especially, say, if we were going to use a matched sibling for a patient with a certain type of mutation that we know can have familial transmission, that's when we may need to test the donor as well to make sure they don't have that mutation, even if they are clinically okay for now. But P53 in general is not transmitted. Can they be tested? Again, since it's not transmitted, usually you won't see it. But in terms of testing, yes, you can do. There are some genetic tests that can be done. However, they're more for what we call the germline mutations rather than the somatic mutations.
I know that the question of passing on their disease is something that a lot of people have questions about. So if someone does have one of those mutations that is typically one that could be seen as inherited or passed down, how early, how late, when, who exactly in the family should be looking at testing, things like that?
Yeah, I think again, that's an area that's evolving so quickly because we have all these really sophisticated tests now that can test for some of those things. Um, I did not. It was one of my colleagues' patient. He came to us for transplant for AML. His mom had gotten a transplant for MDS at another center. And so, so when we saw that patient and got that history, we were worried that something was going on. So we sent him to a genetic specialist, to a geneticist for more testing and counseling. And so when they did the testing, they found that he had the mutation. And so we actually had their children tested for that mutation also, and one of the kids has that mutation. And now it's really like we don't know what to do with this because there is really nothing other than waiting and monitoring that we can do for that child. So that's where I've mentioned like the field is evolving. We are trying to learn what we do when we find a mutation that is more familiar, but and may lead to disease, may not lead to disease. We don't know enough about the natural history at this time. However, yes, what we do for our patients that we suspect could have an inherited sort of familial syndrome is we send them to the geneticist for more testing and then try to appropriately choose donors and things like that. And the other important thing is some of these inherited mutations can also increase risk for other cancers, not just the leukemia and MDS. So we have to be very careful about making sure that they get monitored for all the other things as well, if and when we transplant them.
Thank you so much for answering that and for providing a little bit more insight and information into that topic that I think is on a lot of people's minds. It looks like that is all the questions we had. And so I wanted to take a second. One more question right here at the end. So John says, for those unable to go down the stem cell transplant path, chemo seems to be the only alternative. What about the effects of focus on metabolic health, upping vitamin D levels, keto diet, intermittent fasting, things like that?
I think we need more work to be able to say, in an evidence-based manner, how important some of those other interventions are. I'm not going to discount those, but I'm not really an expert in telling about if those are going to change the natural history of disease. I do feel that some of those things can help, even if you're going through transplant in terms of like exercise or certain types of diets. But um, without really being, or knowing that literature on how will that affect the disease process, I don't think I can comment on that, John.
Thank you so much for your presentation, for answering all these questions. We really appreciate it. And I feel like I've learned a lot. I think everyone on has learned a lot today. So thank you so much. And I
Absolutely.
wanted to take a second to share about one of our programs at HealthTree that kind of can feed into a lot of these questions we've been asking about genetics or questions about lifestyle, things like that. And that is HealthTree Cure Hub. If you were on at the beginning of the call, there's a video that we played that kind of shared the HealthTree model and how our programs kind of play into helping patients best take care of their health. So right now we have over 12,000 blood cancer patients that are using CureHub to track their disease. This allows you to find things like solutions to common disease and drug side effects, participate in surveys. We have surveys in there about lifestyle, things like that help to allow patients to put their information from their head that usually isn't accessible to researchers and get that information into a database where then doctors like all of your guys' doctors can go in and look at that and can help run research. So in CureHub, you can connect your medical records directly from your patient portal into CureHub. This is in place for almost all facilities in the US. If you are not seen in the US, we have a patient navigation team who can go in and help you manually put those in so you can still participate in this program. Once all of your records are in, you can see surveys and studies that are submitted by specialists and researchers like your doctors that you can participate in, see clinical trials that you qualify for, and you can anonymously connect with your genetic twin, which is a really cool program. You can see patients who have similar genetic mutations as you, have been on prior lines of treatment like you, and kind of see what their treatment path has looked like. You can sign up for CureHub and create a profile by visiting the link on the screen. I'm also going to include this link in the event follow-up email, so you can look out for that there. If you run into any issues creating an account, connecting your records, or if you have questions about CureHub, you can reach out to our patient navigators who can help you get started and answer all of your questions. We at HealthTree really believe that patients being able to easily manage their disease and participate in research is how we're going to find cures. So we encourage you all to join. We want this program to be as accessible as possible for all patients. So CureHub is a completely free program, and all of the support from our navigation team is complimentary as well. So please don't hesitate to reach out to them if you have any questions. Well, that's our next meeting coming up is for our MDS community. That's on July 31st on tracking your labs. I also want to highlight a podcast episode that was released just last week for our AML community. I interviewed Dr. Joshua Zeidner from the University of North Carolina on his research into menin inhibitors, which is a new drug class being investigated. The research and the conversation was really interesting, so I encourage all of our AML community members or anyone interested to go give that one a listen. For information or to register for a HealthTree event, you can look on our website, and you can access that page by going to our website, clicking on education, and then picking webinars, or to listen to the podcast episode, our website, click on education, and then select podcasts. I want to take a final moment to really thank our sponsors who help us to be able to have events like this for free for our community. Those are Bristol Myers Squibb and AbbVie for MDS, and then for AML, Servier, Astellas, and AbbVie. And finally, I just want to say thank you to all of you for being here and helping us build our AML and MDS community. Please don't hesitate to reach out to me if you have any questions. My email's there on the screen. You can reach out if you have topics you'd like us to cover in our webinars, or if you have any questions about HealthTree or about your disease, we'd love to help connect you to any resources. I appreciate all of you, and I hope you all have a great rest of your day.